Hi, a very good day to all. My name is Dr. Faris Indra from the Faculty of Medicine and Health Sciences, University of Malaysia, Sarawak, Malaysia. Today, I will talk about my study, the endoscopic evaluation, post-percutaneous tenotomy of Achilles tendon in idiopathic Clubfoot. This is the photograph of my faculty where I'm working at right now. And this is the map showing the location of our faculty from Manila, Philippines. Idiopathic Clubfoot or congenital talipes equinovarus is the commonest foot deformity among newborn. 1 centimeter is the most popular technique used worldwide. About 80% of the patients would require TA tenotomy to correct the hind foot equinus deformity. Various techniques of TA tenotomy had been described, such as percutaneous method using blade or needle, as well as mini-open technique. One of the complications was incomplete division, leading to partial correction of the deformity and early recurrence. The aim of our study is to determine the minimal degrees of ankylosiflexion required, which is equivalent to complete TA tenotomy performed percutaneously via endoscopic assessment. Patients who were classified as CTEV were included in the study. Written consent was taken from the parents. The patients would have weekly foot manipulation and casting, and the degrees of correction was monitored using Faris scoring system. Once midfoot and forefoot corrected, if the hindfoot equinus couldn't achieve 10 degrees of ankylosiflexion, patients would undergo percutaneous TA tenotomy with endoscopic assessment. 9 feet from 8 babies were selected to enroll into this study. The TA tenotomy is performed in operation theatre under general anesthesia. They were performed either by pediatric orthopedic surgeons, pediatric orthopedic fellows, or orthopedic registrars under close supervision. No tourniquet was used for this procedure. Prior to tenotomy, the ankylosiflexion is measured using the sterile protractor. The lower limb was positioned in hip abduction and deflection. The planned surgical incision was marked using sterile surgical marker approximately 1 to 1.5 centimeters proximal to each calcaneal insertion at the medial border of the tendon. The surgical incision is performed medial to the medial border of the tendon using a 15 millimeter blade. At first, the sharp point is pointed towards proximal end before it is twisted until it is positioned at the anterior aspect of the tendon. Subsequently, the tendon is cut in a maximal passive ankylosiflexion. A 2.7 millimeters 30-degree scope is used to explore the tendon before and after tenotomy, utilizing the same tenotomy wound. This photograph shows post-tenotomy measurement of the ankylosiflexion that reveal an undercorrected hindfoot equinus that warrants further exploration and division. This photograph shows measurement of the ankylosiflexion post-tenotomy that shows a significantly improved ankylosiflexion at 20 degrees. After the first tenotomy, the feet is divided into 2 groups. The group 1 belongs to the feet with complete division of the TA. The degree of dorsiflexion is observed between 20 to 35 degrees. The second group consisted of group with incomplete section of tendon Achilles, and they were noted to have less than 20 degrees of ankylosiflexion. These are the intraoperative endoscopic photograph. For group 1, it showed complete TA tenotomy with no remnants of the fibers. For group 2, it shows incomplete TA tenotomy and the remnants of the fibers is either present laterally or medially. For the results, 44% of them have complete tenotomy after the first tenotomy with dorsiflexion of 22 to 25 degrees. For group 2, 5 feet had incomplete tenotomy. 40% of them had incomplete tenotomy at the medial fibers, while 60% of them had incomplete tenotomy at lateral fibers. The dorsiflexion post-first tenotomy was between 0 to 30 degrees, and the dorsiflexion post-second tenotomy is between 20 to 25 degrees. For the conclusion, the endoscopic assessment had found that all cases with complete percutaneous tenotomy had more than 20 degrees ankylosiflexion, whereas the incomplete cases had less than 20 degrees ankylosiflexion. To the best of our knowledge, our study is the first to study the relationship between the completeness of TA tenotomy after percutaneous tenotomy and ankylosiflexion. By using endoscopy technique, we concluded that at least 20 degrees of ankylosiflexion is sufficient to reflect a complete tendon division. However, our limitation is small number of cases enrolled in the study. These are our references. With that, I thank you.